Solitary toxic adenoma. A toxic adenoma is a single autonomously functioning nodule existing within the otherwise normal or non-toxic nodular thyroid gland. The main theory around its pathogenesis focuses on constitutively activating mutations in the TSH receptor gene, although the prevalence of these mutations is not universal and varies widely by geography. Toxic adenoma affects women at a median age of 50 to 60 years with a mild female predominance. Toxic adenoma shares many, if not most, of the diagnostic approach and workup with toxic multinodular goiter. In fact, the American Thyroid Association guidelines on the management of hyperthyroidism combine the two groups together in their treatment recommendations. The treatment philosophy for toxic adenoma generally follows the same principle as those for the toxic multinodular goiter, namely that antithyroid medications are not effective for long-term remission and that either radioactive iodine or thyroidectomy is the preferred method for definitive treatment. Thyroidectomy is typically limited to unilateral lobectomy addressing the site of the toxic adenoma. This strategy is associated with a near-universal cure for the hyperthyroidism. Near-total or total thyroidectomy is indicated only in the presence of other factors such as bilateral nodules with suspicion for cancer or large and/or symptomatic goiter. More recently, percutaneous ultrasound-guided ablative techniques have been described as an alternative treatment options for toxic adenoma and some toxic multinodular goiter. These techniques involve either the injection of ethanol or application of radiofrequency or other destructive energy sources into a nodule of interest. The majority of the published experiences are in Europe and Asia, with limited adoption currently in the United States. These ablative techniques have the theoretical benefit of targeting only the target lesions and reducing the risk of hypothyroidism inherent with radioactive iodine or surgery. However, in practice, drawbacks have been reported, including patient pain and unusual complications such as transient thyroid toxicosis and necrosis of neighboring structures. Currently, these techniques require further study as the lack of high-volume robust evidence precludes their widespread recommendation outside of the experienced centers. The next one is amidarin-induced thyrotoxicosis. Amidarin is an antiarrhythmic medication used frequently for atrial or ventricular tachyarrhythmia. Molecularly, amidarin is an iodine-rich compound with structural similarities to T4 that contains 37% iodine content by molecular weight. A normal dosing schedule can deliver over 100 times the daily dietary iodine requirement. Amidarin-induced thyrotoxicosis occurs in up to 6% of the patient taking this medication. There are two distinct mechanisms proposed in the development of amidarin-induced thyrotoxicosis. Type 1 is caused by the Jod-Basedow phenomenon, in which the high iodine load potentiates excess thyroid hormone synthesis and release. Type 1 amidarin-induced thyrotoxicosis is more common in the patients with pre-existing hyperthyroid disease. Type 2 amidarin-induced thyrotoxicosis usually occurs in patients with pre-existing normal thyroids and is caused by a destructive thyroiditis from direct drug toxicity on follicular cells, leading to release of preformed thyroid hormone. Mixed forms of AIT can also occur. Medical treatment of AIT typically consists of methimazole with a corticosteroid added to address the thyroiditis in type 2 AIT. The decision to halt amidarin treatment must be determined carefully on an individual basis in consultation with a treating cardiologist in order to ensure continuity of adequate antiarrhythmic therapy in these often high-risk patients. Total thyroidectomy is recommended for patients who are unresponsive to aggressive medical therapy. Although thyroidectomy is associated with more risk for AIT compared to most other indications, with perioperative mortality of 9 to 10%, delay in surgery carries an even higher risk of mortality.